Good afternoon, ladies and gentlemen. I'm Mary Pouton, Assistant Dean for Development at the University of Maryland School of Medicine. It's my pleasure to welcome you today to our first virtual Doctors in Dialogue event. Thank you so much for joining us. We're just waiting on our speaker who's about to join us. There she is, Dr. Kotloff. Welcome. About a year ago, the coronavirus began to cripple our nation and our world. On the front line of this fight of the pandemic, the University of Maryland School of Medicine was among the first to begin testing vaccines. Our research was part of the Pfizer, the Moderna, and the Novavax vaccine development. And we look forward to bringing you information today on the COVID-19 vaccines. But before we begin, a bit of housekeeping. Everyone joining us today will have the opportunity to ask questions via the comments section below. Simply select the Q&A box, type your question, and click on the blue comment box to submit. Also, this meeting is being recorded. If you'd like to view it again at a later date, we'll make sure to send you a link, and you can also feel free to share that with others. Now let us begin. Our first speaker this afternoon will be Dr. E. Albert Rees, Executive Vice President for Medical Affairs at the University of Maryland, Baltimore, the John Z. and Akiko K. Bowers Distinguished Professor, and the Dean of the University of Maryland School of Medicine. Dr. Rees.
Thank you, Mary. Thank you very much, and welcome to all who are listening and viewing this webinar. I'm delighted to be with you and to use this medium. I wish it were different. I wish we were together as we have done in the past. It's always nice to see friends and colleagues and alumni from across the country and just to know how you're doing and to get a little way to check in with you. But we have to do the best we can these days, and this is a reasonable way to connect. As I've done in the past, I'd like to give you some highlights of the School of Medicine, of the activities in the School of Medicine the past year. Excuse me. And since we're in a COVID pandemic, I thought I would just give you some really high points on our COVID highlights. Our keynote speaker, Dr. Karen Kotloff, will go into much more detail. But I want to mention that our team, the Center for Vaccine Development and Global Health, has been very much involved in an extensive way in COVID related activities. I also want to mention that one of the members of that team, Dr. Wilbur Chen, professor of medicine, the Department of Medicine, was a member of the Governor Hogan's advisory task force. He's also just been selected as a member of the United States Department of Health and Human Services Advisory Committee on Immunization Practices for a 4-year term. Dr. Chen has been very helpful to us as an institution, both the school, the hospital, and the hospital system, in providing advice on these related issues, since, again, his specialty is infectious diseases, his subspecialty rather. We've also been, as Mary Pouton just mentioned, had been very involved in testing, COVID testing. We developed a platform using our Institute of Genome Sciences, collaborating with our pathology department, and have been doing high throughput mass testing. The last count, and I haven't been up to date, is over 300,000 tests that we had performed throughout the state, whether it be nursing homes or prisons or just convention centers. It's been a real effort to make certain that we did our part in providing value to the state. I should mention that it was just last week that Dr. Tony Fauci joined us in a webinar, and this really was an effort to give an update on vaccines, particularly focused on communities where there may be a history of hesitancy, vaccine hesitancy. And this was a wonderful seminar that I was delighted to be part of. We had over 2,000 attendees either on Zoom or on Facebook. but really was focused on particularly, but not exclusively, Black and Brown communities, where we want to make sure that since they have been heavily hit by the pandemic, they at least avail themselves of the vaccines that are available at the present time. That really went on very well, and we enjoyed it. And there are many faith leaders that was part of the podium and the panel, and we hope to do this again. Now, let me give you a few more high points within the school. We have a series of robust clinical and research programs that dovetail together to make our programs among the best in the nation, as ranked by the U.S. News and World Report. But just to name a few, we have a comprehensive multi-organ transplant program. It happens to be one of the largest in the United States. In fact, there are 5 organs that we transplant on a regular basis with a robust team, a comprehensive cardiovascular and medicine and surgery program. And as many of you know, many of you were students or residents here, or program in trauma or shock trauma program. We've now expanded it to trauma and critical care remains the nation's best and largest transplant critical care program. Also have a very major emphasis in cancer. We now have an NIH comprehensive cancer center, only about 40 in the nation. There are 900 cancer centers nationwide, and only about 40 or so are designated by the NIH to be comprehensive cancer centers. We're one of them. Another area, women and health, women and children's health, diabetes, metabolic diseases. These are just some of the areas that you'll be proud to know that your institution continues to really excel in, and we sometimes refer to as destination programs, where people come to us from outside our region, often outside our state, sometimes across the country, and in some cases across the world. These are our classic destination programs. A little word on education. Well, we have done a comprehensive review of our educational program this year. We now refer to it as the Renaissance curriculum. That has not been done since the 1990s. So we've had a long run of using the standard approach that we've used for many years. Now we've taken a more comprehensive approach, problem-based, and an integration of the first and the second years together, very much a transformation of what we've done in the past. But it's really an enrichment more than anything else. FRCT, Foundations of Research and Critical Thinking, has become a bedrock, a staple, and that is teaching students to be critical thinkers. When you and I went to medical school, the best student was the one who memorized the most and had the best memory. Well, times are going to change. Times are changing. Times will change even more so, because there'll be tremendous amount of data that we'll have to assimilate, analyze, integrate, be able to come to a diagnosis. So we want to have critical thinkers. And so we have introduced the program about 8 years ago. Now, Foundations of Research and Critical Thinking. We're using research as a basis for developing critical thinking. We also have about 8 joint degrees. So it's not only an MD, but an MD or MD and a PhD, or an MD and a series of masters, whether it be public health or molecular medicine. So it gives students a variety of interests. Students nowadays have varied interest in engineering, interest in business. So they now can do an MD with a business degree, an MD with an engineering degree, an MD with a public health degree. These are offerings that give diversity and give really a platform of flexibility. The last point I want to make before I conclude is just that we continue to be very effective in how we use our dollars. In fact, I like to say we're very frugal in how we use our dollars to really invest into our people, into our infrastructure, and into our future. Therefore, philanthropy has become a bedrock to help support those efforts. I want to point out that last year, just between gifts and foundation awards, we ended the year with a $58 million purse. That really was important to help with scholarships, help with investment in new faculty, but a very important part of our revenue base. And I would want to thank our alumni who have been generous, reliable, and just enthusiastic in their support of your school. So let me thank you very generously in what you have been doing to support your institution. So once again, it is just a pleasure for me to address you. And once I wish we were doing it together, but hopefully next year we can get together and see each other. And until then, you stay safe, stay well. Let's stay in touch. I'll transition at this time to our moderator, Mary Pouton. Thank you very much.
Thank you, Dean Reese. We appreciate your comments. The School of Medicine is proud of our strong partnership with our Medical Alumni Association. And so now I'd like to invite the Alumni Association's Executive Director, Mr. Larry Pitroff, to bring greetings on behalf of the MAA. Larry?
Well, thank you, Mary. It's wonderful to see so many familiar faces. This has been a very challenging time for all of us, but the reality is that this is not a bad mode of communication if you look at what the alternatives would have been 15 or 20 years ago. It is an absolute pleasure to be collaborating with the medical school to be able to offer these wonderful programs. We know you're going to find this very informative today, and we hope to do a lot more. I also just want to put in a quick plug for Reunion. Our reunion has gone virtual as well. Many of you know that, set for the spring. But just watch your emails and things for updates. Most of the classes are going to be doing some virtual gatherings, but we're also going to be doing our annual meeting, our awards ceremony, and of course, the medical school gala. So just, we'll keep in touch. It's a pleasure seeing you. Welcome. Thank you for participating. And as Dr. Reese said, we really do appreciate this continuing support. Mary, back to you.
Thank you, Larry. I appreciate it. Now it's my pleasure to introduce you to our presenter this afternoon, Dr. Karen Kotloff. Dr. Kotloff is a professor of pediatrics and the division head of pediatric infectious diseases and tropical medicine. She is also the associate director for clinical research at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. Dr. Kotloff has held numerous large epidemiological studies and clinical trials to evaluate vaccines against a wide range of infections in the United States and developing countries. She serves as a principal investigator for the Vaccine Treatment and Evaluation Unit at the school's NIH-funded Center for Vaccine Development and Global Health. Dr. Kotloff was the principal investigator on the phase 3 human trials of the Moderna COVID-19 vaccine. So please welcome Dr. Karen Kotloff.
Thank you so much, Mary. And it's really a pleasure to be here with my extended family. And let me see if I can be lucky enough. I haven't had much luck with sharing my screen today for some reason. And it may be that you guys have this is the second time it happened today where it doesn't show up. Are you able to put up my slides? Okay, great. Okay, sorry about that. Thank you. So if I could have the next slide, please. Okay, so to start off a talk about vaccines for COVID, I think that it's just helpful to really just take a second and look at what this virus has done to the world. So right now, COVID is widespread throughout the entire world. There have been more than 102 million cases and 2.2 million deaths. Next slide, please. In the United States, we have about 20 to 25% of the total cases in the world, or about 26 million and 440,000 deaths. So we're carrying a huge burden in the US. And right now there is more than 1 death per minute occurring in the United States. What's a bit of good news, if you look at the pink slide, you can see that we had a first little bump, a second little bump, and then a third big bump. And that's what many call the first, second, and third wave. And we seem to be coming down from that third bump a bit. So that is the silver lining, and we'll have to wait and see what happens. Next slide, please. So when we're talking about vaccine development, the most important thing to keep in mind is the spike protein. The spike protein is what is responsible for that crown, the coronavirus. That is the crown of the virus. And that's made of these little proteins that stick out that make beautiful diagrams. And those spikes are what the virus uses to attach to receptors on our cells, particularly in the respiratory tract, but we have those receptors throughout our body, and fuse with our cells and enter our cells and cause infection. Next slide, please. And if you just look at these 3D images, what you can see is the spike protein sticking out from the coronavirus, and it's aiming for the human ACE2 receptor on human cells. Next slide. And here it is attaching, and then next slide. And this is in the presence of antibodies. So those little kind of three-armed wheels are antibodies. And so when antibodies bind to the spike protein, it can't fit like a lock and key into the human ACE2 receptor, and you can prevent infection. And so all of the main vaccine candidates that are being studied right now are based on that spike protein in different presentations. Next slide, please. So this is how vaccines this is how the pipeline is being managed in the US. With the new administration, we don't have Operation Warp Speed. The name is not the same anymore. I don't remember what the new name is, but this was previously Operation Warp Speed that was responsible for selecting the vaccine candidates and providing the funding to put those candidates through the clinical development pipeline and also the manufacturing pipeline. And it was this huge influx of funds that allowed things to move much more quickly and to conduct very large trials so we could get answers very quickly. The vaccine trials are being conducted in two venues. If you look at the bottom, there are the NIH, NIAID funded venues, and the Vaccine Treatment and Evaluation Unit is the grant that Mary mentioned that I've had since the I think 2006. And we use that to test vaccines of public health importance. And so we formed together into a network called CoVPN. And then there are also commercial sites that are testing the vaccines together with us. And that's the network, and this is how the authority flows. Next slide, please. So how are vaccines developed? There are 3 phases of clinical trials after lab and animal studies show that a vaccine has promise. Phase 1 is given to small numbers of people, and it's to pick up big safety signals and make sure that the people who are vaccinated are getting the signals that look like they have protective immune responses. Phase 2 moves more toward the target population. So for coronavirus, that could be people with underlying conditions and eventually elderly, and it's larger numbers to get a better idea that the vaccine is safe and has a good immune response, and you can look at doses and vaccine schedules and kind of optimize things. And then phase 3 is the great big, large placebo-controlled trials in the target population. So you give vaccine to one group and placebo to another group, and they're out in the community where the infection is circulating, and you look to see whether the vaccine prevents disease. So you can compare the rates of of illness in the vaccinated versus the placebo recipients. You can also see whether the vaccine lessens severity and look at a number of secondary aims. And safety is always a key parameter in vaccine trials. Next slide, please. So this is the buffet that Operation Warp Speed selected for clinical trials. They picked 2 of each. It's a bit like Noah's Ark. So there are 2 messenger RNA vaccines, one made by Moderna and the other by Pfizer. There are 2 adenovirus vector vaccines, one by AstraZeneca, the other by Johnson & Johnson. And then there are 2 there are 2 recombinant protein vaccines that are given along with adjuvant, and that's Novavax and Sanofi in collaboration with GSK. Next slide, please. So how do messenger RNA vaccines work? What you do is you can synthesize the genetic code, which is messenger RNA, for production of the spike protein. And some very smart investigators at NIH were able to understand how the spike protein, the conformation that would be ultimately protective, because the spike protein has these flapping motions. And so it can kind of hide its most vulnerable, the binding parts, by flapping down. And you want to keep that flap up so that the receptor binding parts of the spike protein are exposed to our immune system. So that's how most of these candidates configure the spike protein. So you inject the spike protein and it goes into our muscle cells, and our cells, you inject the messenger RNA, in a lipid envelope. It goes into our muscle cells. Our cells then produce spike protein, express it on the surface of our cells, and then our immune cells sense that as foreign, and they make antibody and cell-mediated immunity, and we are then protected. We have all the armamentarium we need, so when we see the actual coronavirus, the SARS-2 virus, we can make the correct protective immune responses and stay healthy. Next slide, please. What's important to know is that the mRNA vaccines cannot alter DNA. It doesn't have the machinery. It doesn't exist inside the nucleus. It's only in the cytoplasm. It doesn't have any signals or ability to get into the nucleus where it could incorporate into our genome if it were able to have that access. And there's no known reverse transcription sites that would allow it to become DNA and incorporate itself into our cells. So it's very safe. It's a very flexible way for making vaccines. It's been a huge advance. The science that this vaccine development has brought to the forefront is really quite remarkable. Next slide, please. So if you look at the 2 candidates that contain non-replicating viral vectors, go back up one, please. Both of those contain adenovirus. So the AstraZeneca is a chimpanzee adenovirus, and the Janssen is an adenovirus serotype 26. They can't replicate, so they can't cause infection. But what they do is you have the genetic code for the spike protein inserted into their genetic code, and they make spike protein and present it to our immune system to get the immune responses that we want to protect us against later exposure. And then finally, next slide, please. There are 2 vaccines, one by Novavax and the other by Sanofi Pasteur, that are actually just the spike protein in the perfect conformation. And so these are recombinant. They're made inside of insect cells, and then they're purified and mixed with like a detergent. And so they form these little virus-like particles that are just the right size so that our body thinks that it's actually a virus when really it's just the spike protein and some detergent. And it's given along with an adjuvant. And so in the case of Novavax, that's Matrix M, which is made from a soap bark tree, and that's a saponin. And together it's quite immunogenic. Next slide, please. So I think probably you all know, anybody who reads the New York Times, which is my favorite medical journal, that spike proteins, the natural spike protein on coronavirus has been kind of throwing a hook at us after being so kind to present itself as such a great vaccine antigen. There are mutations that are starting to appear that have impact on potentially on vaccine efficacy and on the efficacy of monoclonal antibodies. So there are really three major variants that are getting a lot of attention. One is the UK variant, and that's the B117. It's also called 501Y variant 1. And that is spreading widely in the US, and it's thought to become the dominant variant that will be in the US. And so people are very concerned that that downswing that we're seeing could be reversed because these mutants are more transmissible, and there was a signal that they could increase the risk of death. And so we're watching those very closely. There are also mutants there's a South African strain and a Brazilian strain, and they both have increased transmissibility. And there's no evidence yet that they have increased severity, but they could interfere with vaccine efficacy and efficacy of monoclonal antibodies. So they're being watched very carefully. Next slide, please. So what do we know about the efficacy of these vaccines so far? It gets a little confusing, and I tried to make it clear. So the Pfizer and the Moderna vaccines were tested in the US before these variant strains emerged, and the overall efficacy of both was very similar. They're very similar vaccines. It was about 95%, high protection against severe disease, and even some protection against one dose. It's the information that you get about one dose efficacy can be confusing because the efficacy from the vaccine really doesn't kick in for about 2 weeks. So if you just start at 15 to 21 days, you can see much higher efficacy following dose 1 than if you start at the time that the vaccine was given. And so that's why this range is seen. But amazingly, you can get up quite high if you just look at that later period when your immune response kicks in. But we don't know how durable that response will be. It's not nearly as high as the response that you see after the booster dose for most of these vaccines. So nobody's ready to give up the second dose. So the other two, the adenovirus-based vaccines, have had data that has been released from studies in the UK and Brazil and Africa. And those results have been a little bit more variable. AstraZeneca had very high efficacy, 90% in the UK, but it was only in people less than 55. And it was in a unintended low dose, high dose regimen. If you look at the intended regimen in Brazil and in the UK, the efficacy is a bit lower. They're going to look and see whether a second dose can improve that. And then the Janssen vaccine in the US was about 72% lower in Latin America and South Africa. But this is after a single dose. And the efficacy against severe disease is really high. And so, I think that people look at that and say, well, it's not really good. I wouldn't take it. But if you don't get severe disease, I mean, that's the bottom line. If you just have a respiratory illness that kind of knocks you out for a day or two, it's not really a big deal. So I don't think people should really think that that vaccine should be discarded or it's less valuable. I think it's, part of our toolkit. And then finally, the Novavax vaccine is undergoing trials still in the US, but there were results that were just released from the UK and from South Africa, and it showed very high efficacy, 89% overall in the UK, and it was 96% against the non-variant and 86% against the variant. So that's very reassuring. But unfortunately, in South Africa, which was almost all the South African variant, the efficacy was less than 50%. These have different storage conditions. And so, you know, the message here is that there are different, that we now have a whole toolbox of vaccines. The Novavax results in the US will come out in a couple months, and they have different qualities that could make them good in different situations. Next slide, please. So this just shows we participated in the Moderna vaccine, and our investigators were shown in the New England Journal paper. And what you can see in the graph on the top is that starting at about 14 days after vaccination, you don't see any more infections in the vaccinated group, while in the placebo group, they continued to climb. And that efficacy for these messenger RNA vaccines is similar in all age groups, in men and women, and in all race and ethnicity groups tested. Next slide, please. So what are the side effects of these vaccines? Some of you who may have gotten the vaccine already can tell your own story. They tend to be more common in the younger adults, more common after the second dose. Most of the time they go away in 2 days. Fatigue, headache, and chills were the most common. And local reactions that were seen were mostly sore arm and pain. Not much in the way of redness and swelling. Severe symptoms were rare. Fever occurred occasionally, and some people felt uncomfortable enough to take medication. Next slide, please. So I'll just close in kind of just giving a little insight into what we've been doing. So we participated in the phase 1 Pfizer study, in the phase 3 Moderna study, and now in the Novavax study. And we've been very, very busy. We enroll close to 500 participants in each of the 2 phase 3 studies. We're using beautiful space that was lent to us by the dean to be able to conduct this study, which is quite complex. And we also opened up a satellite site at Casa de Maryland in Langley Park in a Latinx community to be able to reach out to high-risk people and offer them the opportunity to participate in these vaccine trials. So we have data on a diverse population. Next slide, please. Community engagement, as the dean said, has been a very important part of what we do. There is a lot of vaccine hesitancy in our community, and there is a lot of room for building trust. And so we have many collaborators in both the Latinx and the African American community to try to encourage them to participate in our trials and to accept the vaccine when it becomes available. And that's a picture of the president of UMBC, Freeman Rabowski, getting vaccination at our site. Next slide, please. And this is the webinar that the dean spoke of. So what we set up was a webinar where the panelists were faith leaders in the community, and Dr. Fauci was there with us, and they got to ask questions. There was a very rich discussion that we really enjoyed. There's the dean there also as a participant. And so that was really a very meaningful experience for a lot of people and had a large outreach. Next slide, please. So what do we need to do next? Well, it's really important to understand what we can do with the variants, and several of the companies are already making multivalent vaccines that will contain the leading variants. And so there are studies to see if you give a boost with those vaccines, will that broaden the immune response and suggest coverage of these variants. And then we're, going to need to follow the safety and protection to see if it continues to be durable over the months, because we're very early in these trials. And we still need to know, can we throw away our masks? Right now we can't, but we need to know if these vaccines prevent asymptomatic infection and will decrease transmission. We need to know if it works in children and pregnant women and people with immunosuppression, and whether we can have more stable formulations that don't require deep freeze like the Pfizer vaccine, and even a bit less so for the Moderna vaccine. And I think that is my last slide, or one more after this. Just that's one of our little recruitment postcards that we have for our vaccine trials. We've had really an incredible amount of support from the community. Our recruitment's been outstanding. So I'm happy to take any questions now. Thanks.
All right. Thank you very much, Dr. Kotla. We appreciate it. We do have some questions here. And so I'm going to go through them. And can the second Moderna shot be given at 5 or 6 weeks versus 4 weeks if it's not practical to get it in the exact 4-week time frame?
Yeah, so that's a good question. It's a big practicality. So of course, when you do a clinical trial, you just know how well a vaccine works when it's given exactly according to the vaccine trial. So we don't have specific data, but our experience with vaccines is that if you give them a little late, that booster dose, you don't lose anything. It's more harmful if you get it earlier. So a week or two after should not hurt, and it may even be beneficial, but we don't know yet.
And another question, and kind of on top of that, is someone asked, should you get your vaccine at the same site? I guess I believe that whenever someone gives you your first vaccine, they're responsible for your booster shot.
You mean not at the same site, not in the same arm?
I think they meant at the same place. Do you need to get your vaccines at the same location?
Yeah. So what the health centers, health facilities are doing, and this will probably happen in the community, is there's no data on mix and matching different vaccine formulations, Pfizer and Moderna. And so the way to keep that organized is to have each site responsible for giving a certain vaccine. And so if you start switching sites, there could be confusion, the records may not be shared. And so I think it's, hugely advantageous to go back to the same site.
All right, another question. After the injection of the mRNA, where in the body is it utilized to generate the COVID spike protein?
So it goes into your muscle cells at the site. And most of it remains there, and then it makes the spike protein that it displays on the surface of those cells, and that attracts your immune cells that make antibody and also cell-mediated immunity, both of which we think are very important in protection. The cell-mediated immunity may be more important for severity, and the antibodies more important for acquisition. And so then your antigen processing cells, your immune cells, recognize this foreign thing, and they do their thing to make you protected. The first dose is kind of a wake-up call, and the second dose really allows you to have a stronger and more mature response.
Great, that was very interesting. I didn't realize that. That's interesting how the body changes with the second dose, so that's neat. Okay, it's been stated that people who have COVID should still take the vaccine. However, recent studies have shown that previous infection with COVID leads to more intensive reaction to the vaccine. Is this true? Should a previous infection mitigate against taking the vaccine?
So right now, what we know about infection is that it protects you for about 90 days. We know that it makes memory cells, and so the protection could be longer, but we don't know that. And so getting vaccinated mitigates against the possibility that infection-derived immunity is short-lived. And actually, in the Novavax trial, they showed that people who had antibody, so indicating previous infection at the time that they enrolled, those who were vaccinated were more protected against COVID than those who weren't. And so that's pretty strong evidence that you will get more protection if you get yourself vaccinated, even if you've been infected. The initial CDC recommendations said wait 90 days. They're kind of pulling back on that. The reason they said that is because you'll be safe for 90 days. And then when your natural immunity starts to wane, the vaccine will come on. But now they're saying that it's not necessary. And there really isn't good data to suggest that you'll have a more severe reaction, as far as I know, at least.
Right. The next question is, I'm hearing concerns about blunted immune responses if Tylenol or ibuprofen are taken. Can you speak to this?
There's no systematic data on that. In the trials, it was not recommended to prophylactically take anti-inflammatory agents or analgesics. I think that it was done fairly routinely in the UK trials of AstraZeneca, but there's not really much data. And at least CDC is pretty open and saying, if you feel bad afterwards, it's okay to take anti-inflammatories or analgesics. But you have to recognize that there's no data really.
All right. And then what do you think about the role of antibody testing before a vaccine? Is it feasible in certain communities?
So I don't think that antibody testing has any role, because I think whether or not you've been previously infected, you should get the vaccine. There have also been, just as an anecdote, people who have been in our trials who went and got antibody testing and said, oh, I don't need to unblind. I don't have antibody. I'm going to go out and get Pfizer vaccine when I'm in the Moderna trial. The antibodies that are tested commercially may not be the spike protein antibodies. They're frequently nucleoprotein antibodies. And so you could be negative for antibodies and be fully immune. So don't use that as a sign about whether or not you are immune from your vaccination. So the bottom line is you don't need to take it before you get vaccinated, because it's not going to change what you do. And you shouldn't take it after you get vaccinated, because it's not going to tell you whether you're immune.
All right. Then for those who get the first shot, then get infected and are symptomatic, should they get the second shot? And if so, when should they get it?
They should get the second shot when they no longer have symptoms. And depending on the vaccine, if the vaccine's given every 21 days, then at least 21 days later, or at least 28 days later, they should have no symptoms.
All right. There's a group of patients who are termed long haulers who exhibit vascular symptoms months after their initial illness. Is this an autoimmune reaction? If so, is the risk for the immune system to cause a chronic illness in a small group of individuals?
So this is being studied. I don't think that there are definitive answers. I think that one hypothesis is that it can infect your endothelial cells and you can have kind of small infarcts in lots of places. and that can be responsible for some cognitive and kind of feeling of mental changes. The fatigue, I don't think there is a good understanding of the fatigue. There's a lot of interest in the significance of the persistent loss of smell and taste. But these are all being investigated. I don't think that there's been any evidence of an autoimmune phenomena going on, but I think it's too early to know. And then what was the second part of your question? Or did I answer? Maybe
I think you answered the question. Okay. There was another question about, is there any data on the severity of vaccine side effects when you previously had COVID-19 disease? And the example they give is my 50-year-old sister and her husband had the disease approximately 90 days prior to getting the Pfizer vaccine first dose. And then they had pretty bad muscle pains in their arms and upper backs.
So it's really hard to know in an individual case when you have reactions, if that really is a pattern. The best way to look for those patterns is in the placebo-controlled trials. And right now, there haven't been signals to suggest increased severity in particular situations. But there's a lot of data that has not yet been teased apart. You know, what people are really looking at is the efficacy and the safety right now.
Okay, then I think you answered this. The Moderna and Pfizer are actively working on the boosters for the variants, right, against which the current vaccine is potentially ineffective. So they are working on boosters. Is that correct?
I know for a fact that Moderna is doing it and Novavax. I haven't read specifically that other companies are, but it's hard to imagine that they're not.
And I had another question about we talked about the vaccine. Should we get it at the same location? And then I didn't see this other question. Is it supposed to be in the same muscle?
So it really, there are, some of the studies don't pay any attention to that. And some of the studies say, if possible, do it in opposite arms. I don't know.
That's still a kind of an unanswered question, right?
Yes.
All right. So another question is, so are there any problems with lymph adenopathy after injection number 2? Adenopathy?
Yeah, so there are volunteers who get axillary adenopathy. And what I've seen in a couple of our volunteers is they've gotten some swollen glands in their neck, which really doesn't make sense because that shouldn't be part of the drainage pathway of a shot in your arm. But I've seen, maybe 2 or 3. I'm not sure what that means.
All right. A patient needs an epidural nerve block for chronic pain. How long after the second immunization should the epidural be deferred as it contains a steroid?
So the way that the studies have been designed is that most of them have excluded people who were on high dose steroids within 14 days prior to vaccination or who are on other immunosuppressive drugs. So the vaccines haven't been tested in those situations. There's no contraindication for taking steroids post-vaccination. And even in the trials, that was not prohibited.
All right. To the point that I've heard that mammograms should be delayed after immunization because of the risk of that adenopathy. Have you heard that?
I haven't heard that.
All right.
I don't know the answer to that. I guess what I would probably do is ask your physician about that, your gynecologist about that.
All right. Can you comment on patient who have fillers? Is it okay to get the second shot if they've had inflammation after the first shot?
So it's pretty interesting. There has been an association with hyaluronic acid fillers for cosmetic reasons. For example, injections into the lips. And I did have one of my participants who had actually, she didn't mention it, but she had that angioedema after her vaccination with flu a year or two before. And then after her second dose had huge angioedema, it was without hives. And there has been an association with these fillers and either facial or lip swelling. And so it's not an anaphylactic reaction. It can be kind of startling. And right now it's not a contraindication, but it'll probably make its way into a warning about a drug-drug interaction.
All right. Do the severity of the side effects experienced after the vaccine predict the severity of illness that would have happened if you weren't immunized?
No, I guess I can say no to that because the reactogenicity is less in elderly people and the disease is worse in elderly people. And I think both of those things reflect a weakening of your immune response as you age. And so you have less of an inflammatory response to the vaccine, but you also can't fight the virus as well.
This question is, some patients are pushing back on the willingness to get the vaccine because it has been reported that they have been made from aborted fetal tissue. Can you address this?
Yes, so there has been testing in cells that have been made from these cells. I'm trying to get it straight in my mind. These cells were collected from elective abortions in the 70s, and these are cell lines. And the effectiveness of some of the vaccines were tested in those cell lines. But those cell lines have not been used to actually make the vaccine. There has been outreach to religious communities, and in general, I just know this from the internet, so you'll have to take this with a grain of salt, that they have been supportive of the use of these products in the way that they have been used in these the development of these vaccines.
Thank you. And why is there a delay of 2 weeks after getting Shingrix shot to get the COVID shot?
So why is there delay? In the clinical trials, we did separate giving other vaccines from getting the COVID vaccines. And that's because it's very difficult, if you do have a safety issue, to be able to distinguish whether it's due to one vaccine or another. The Shingrix vaccine is particularly reactogenic. And so the rationale, I imagine, is that you don't want to have a vaccine that's giving you reactions, 2 of them at the same time. So you could compound the problem. And then you wouldn't want the responses to really overlap. I think it's probably just caution.
If a patient is being treated, can he still have a shot?
If he's being what?
If he's being treated for MS, can he still have the shot, multiple sclerosis?
So I'm a pediatrician. So are these immunomodulating drugs that the patient will be getting?
I'll wait and see if they respond to that, but they did not.
Okay.
But those kind of drugs might have an effect if they got the vaccine?
Those, yes. So for the most part, people who got drugs that could affect your immunity were excluded from the trial. And so we don't know whether they would have less of an immune response. And in general, if you fall into that category and you develop COVID, even though you've been vaccinated, you should investigate whether you might benefit from monoclonal antibody to lessen the severity of your infection in case you weren't able to mount a strong response to the vaccine. So you should talk to your doctor about that.
Great, thank you. And that was that kind of drug, so they did confirm that. So, okay, is the University of Maryland doing sequencing of virus to determine variants, and what percentage of cases are sequenced?
So the University of Maryland has the capability of sequencing viruses, and for various research purposes, they are doing sequencing. I don't know whether they're part of the public health response and CDC's response. And I think with the new administration, they're trying to ratchet up the number of viruses that are being sequenced because we don't have a good feel for how widespread these variants are. The South African strain was detected in Maryland, I think yesterday. I'm sure the UK strain is widely spread, and we need to understand that because of all kinds of issues, including how it will affect the response to vaccination.
Dean Reese, there's a question for you. What has been the involvement of students in the vaccine trials? Karen, you might be able.
Sure, we've had students who have volunteered to participate in the trials, and certainly they've been very helpful in general throughout the COVID pandemic. As to any other specific involvement of the students, I'm going to ask Dr. Kotelov if she's aware of anything beyond themselves being patients or subjects, I should say.
So a requirement for all the trials is that you need to have the potential for exposure to COVID. So if you're sheltering in place, we discourage those people from being in the trial because we need to see whether the vaccine prevents infection. So you wouldn't be able to tell that if people had no risk. So medical students who have risk would be accepted into the trial. My recollection is that especially during the first part of the trial, as a medical rotation, they were not being put into situations where there could be exposure. But we would certainly welcome medical students being on these rotations if it was acceptable.
And Dean Reese, there was another question about, are the medical students then getting vaccinated?
The answer is yes. What we've done, as you know, the CDC has certain guidelines. The 1A categories are those who are frontline workers, particularly taking care of or exposed to COVID patients. So they're usually not a part of that. But the 1B is where it's really all of the clinicians who are caring for patients, and those third and fourth year students in the 1B category were vaccinated in that category. The first 2 years, they're essentially in the classroom. So they're not part of the early vaccination pool. They'll be like part of the general population. So the answer is yes with a certain group, and no until the general population is vaccinated. They will get their time will come.
So they asked me to repeat your answer for the question if a 45-year-old patient with MS with monthly infusion should get the shot. I think they wanted you to just repeat about what you said to talk to the physician about.
Yes. So if you're on immunomodulating therapy, that could potentially weaken your response to vaccination. That's not a contraindication for getting vaccinated, But if you were exposed to COVID and developed COVID, then you would want to, pretty immediately talk to your physician about whether you're a candidate for getting monoclonal antibody, because, you still potentially, if you didn't have a strong enough immune response, you might get ill. And so you may want to see if you should be double protected.
And that's another question about immunity developed in people who are on immune suppression for any reason, right? That would address any immune suppression situation for anything.
It would.
Okay. Thank you very much, Dr. Kotloff and Dean Reese. We're out of time. Lots of questions today, lots of participation. We appreciate it. This concludes our afternoon discussion. We want to thank you all for tuning in today, and we look forward to being able to have you join us in real life at a future Doctor and Dialogue event. Thank you so much. Have a great day.
Thank you. Bye-bye.